Okay, everyone. Well, thank you for tuning in to the webinar on difficult donor dilemmas today, hosted by the ISHLT Infectious Disease Community. Um, I'll just share my slides. We've got three interesting cases to discuss today with an expert panel. And just a reminder to anyone, if you have any questions, to please enter them into the chat, and we'll aim to address those as we go. Before I begin, I just wanted to give a quick plug to get involved with the ISHLT ID professional community who organized this webinar, and also a reminder that to get your tickets to the ISHLT annual meeting that's occurring in April in Toronto. I think early registration is still open for a few days, so please get your tickets while you can. So our moderators today are myself, Brennan Collis from Austin Health in Melbourne, Australia, and our second moderator is Dr. Joanna Nelson from Stanford University. Our panelists are Dr. Jack Haney from the Mayo Clinic in Jacksonville, Dr. Stephanie Pouch from Emory University, and Dr. Joanna Schaenman from UCLA. So I'll just start by throwing to Dr. Joanna Nelson just to give us a brief introduction on donor-derived infections.
Thanks so much, Brennan. To start, I wanted to get us all on the same page by going through some definitions. So, donor-derived infection itself can be defined as any infection transmitted from the donor to the recipient during the transplant. And we can really divide these into two large buckets. The first is expected donor-derived infections, and these are any infections that we might know about at the time of transplant. For example, a donor who's NAT positive for hepatitis C, or a donor who has an E. coli bacteremia. And typically, we can manage the recipient with either preemptive therapy, universal prophylaxis, or targeted therapy. And in doing so, outcomes are usually quite good in recipients and are not significantly altered by these infections. On the other hand, we have unexpected donor-derived infections, and these are those that are not known at the time of transplant. And this might be because clinical disease is not recognized in the donor. Screening is either not done for their particular pathogen, or many of our screening tests are imperfect, so may have kind of missed the diagnosis of this infection. Um, Unexpected infections more often occur in deceased donors, but can also occur with living donors. And overall, these infections are rare, but really importantly and important to recognize because they're associated with significant morbidity and mortality in recipients. Next slide, Brennan. So, oral organ biovigilance practices really vary across the globe. Some countries having no particular monitoring of donor-derived infection, some relying on voluntary reporting. In the US, this is done through the Organ Procurement and Transplant Network, OPTN, Ad Hoc Disease Transmission Advisory Committee, or DTAC. And here, mandatory reporting is done of suspected deceased or living donor transmission events. And this reporting is really only mandatory for those unexpected infections, not the expected category. And the DTAC will take this data and review it in a blinded fashion to determine the likelihood of transmission to the recipient. And using this comprehensive data, this allows for accurate assessment of donor transmission trends in the US, also community education on risk reduction, as well as, importantly, development of policies to both improve safety for recipients as well as safely expand the donor pool. So this is data from a 10-year report from the DTAC from 2008 to 2017. And during this time, there was about 2,100 reports of potential donor disease transmission events. 15% of these were classified as proven or probable donor transmission, with the most common etiology being infection in 67%, and then malignancy in 29%. Fortunately, unexpected transmission was quite rare, occurring in less than 0.18% of all transplant recipients. But again, importantly, this can be associated with significant morbidity and mortality. And in this cohort, graft loss or death occurred in about one-third of the patients with donor-derived disease, with the highest rates being seen with malignancy or parasitic and fungal diseases. So, what can we do to mitigate the risk of unexpected donor-derived infection? The best tools we have are really kind of the medical history that we are given, reviewing that thoroughly, as well as some of our screening tests. So, again, here in the US, we have a standardized form given to all um, family members of donors to fill out about their history, which is this uniform donor risk assessment interview. But an important caveat to remember is this data is only really as good as kind of the data you're getting in. So it really there can be some variability in terms of how well next of kin know the donor. But the type of questions that are asked and the type of history that's obtained include a thorough past medical history as well as social history, including things like place of residence, travel history, occupation, certain exposures like incarceration or insect bites that may give you some clues as to epidemiologic risk in the donor for certain types of pathogens. Another important clue can be how long their duration of recent hospitalization was, because longer hospital durations are associated with multi-drug resistant organisms. And one important thing to highlight and look at is what the cause of death for the donor was. Often we have we might not get a lot of history in this regard, but it can bring up certain questions. Like, for example, is there any association with infection risk from the cause of death itself? For example, in a patient who may have overdosed using IV drugs, there's a certain risk for transmissible infections to come along with that donor. And lastly, does the reason for death, is that consistent with their medical history? This is something we'll get into a bit more in detail with one of our cases, but if there seems to be some gaps there, that might raise a red flag that there may be some underlying occult infection at play. And then lastly, another tool we have is the screening tests we do. So on the left, you'll see a list of the standard screening that's done in the US. And often we also have images to review as well for our donors. And then to the right is certain screening that may be done in the setting of certain geographic or epidemiologic exposures, including testing for endemic mycoses, strongyloides, HTLV, Trypanosoma cruzi, and tuberculosis, to name a few. So with that, I'll hand it off
Okay.
to Brennan for the first case.
Thank you, Dr. Nelson. So yeah, starting with the first case, it begins with a consult to the transplant ID team on post-transplant day 6 for Aspergillus on donor BAL culture. So our recipient is a 25-year-old male who has congenital heart disease, and they had a Fontan procedure in early childhood that was later complicated by Fontan-associated liver disease. Prior to transplant, our recipient was working as an EMT, and he's currently status post-heart liver transplant 6 days ago. Our patient received basiliximab induction. The donor recipient serostatus for CMV was intermediate risk D minus R plus, EBV intermediate risk D plus R plus, and toxo intermediate risk D plus R plus. And of note, the donor hepatitis B core antibody was positive with a negative surface antigen and a negative NAT. Our patient was doing well. They were extubated on day 2, and they're currently receiving standard antimicrobial prophylaxis at our institution, which includes ganciclovir for intermediate risk CMV, trimethoprim sulfamethoxazole for PJP and toxoplasmosis prophylaxis, tenofovir alafenamide for the positive Hep B core antibody, and antifungal prophylaxis with inhaled liposomal amphotericin B and clotrimazole troches. Looking at our donor is a 36-year-old male. Their cause of death was an out-of-hospital cardiac arrest. They were initially found to be in ventricular fibrillation and had 35 minutes of downtime before return of spontaneous circulation, and then were subsequently declared brain dead. In workup for this, the urine toxicology was noted to be negative. Unfortunately, we did have some limited medical and social history on the donor, but what we did understand is that the donor was originally from Guatemala, where they worked in the construction industry there. They came to the United States approximately 4 months prior to their death and was held in immigrant detention for a period of time. And our donor also had a respiratory viral illness, which was noted to be the flu 1 month before their death. In workup for their donor evaluation, the CT chest was noted to identify some nodular opacities in the upper lobes, thought to be related to an infectious or inflammatory process. And then after organ procurement, we've got this donor BAL result with Aspergillus niger. So I just wanted to start throwing to our panel with my first question. So to the panel, what do you think is the significance, if any, of this Aspergillus niger result? And then what other infectious considerations do you have for this donor?
Well, thanks for that start off to the case, Brennan. This is a really fantastic case to talk about and a lot to think about as I was, thinking a little bit about some of the donor history and the recipient underlying disease. So, I think as far as the significance of the Aspergillus niger, I'll say it's really hard to know. To be perfectly honest, sometimes, we can see, scenarios in which the donor does have known Aspergillus colonization of the airway, commonly in individuals who may have underlying structural lung disease. But it is a little bit curious looking back through his history. I'm presuming, again, out of hospital arrest. I don't know kind of where the donor was located at that time or what other more recent exposures were. But, knowing his medical social history, at least what we're aware of, we know that at least he had worked in construction, and getting to your next question, hailed from Guatemala, came to the US a few months ago, and specifically moved to Ohio, where he has other potential exposures to endemic mycoses like histoplasma. And then the other thing in the back of my mind as well is, knowing that he had the flu a month prior, the question that initially comes to mind is, was this really the flu, or could this have been reflective of another acute kind of respiratory illness that may or may not have been viral in nature? Or if he did have the flu, could there have been a potential for post-influenza aspergillus colonization? So these are all things that are crossing my mind. And I think the other issue that I'm thinking of as well, knowing that there are opacities, particularly nodular opacities in the upper lobes, make me think a little bit about what his TB status might be, knowing that he did come from a country that's endemic for TB, and was also held in immigrant detention, presumably in a congregate setting. So these are some of the thoughts that are going through my mind. But at this point, not entirely clear that the significance of the Aspergillus niger, particularly for this recipient, knowing that Aspergillus niger is probably less likely to cause invasive aspergillosis compared to some other Aspergillus species. So in my mind, not entirely clear whether this is just a colonizer or something to be more concerned about based on what we know now. But I'm leaning more towards colonization. I don't know, Joanna, if you have other thoughts.
No, thank you, Dr. Patch. I completely agree. And I think that these positive fungal cultures are relatively common. So tying it into the donor history and the radiology is exactly what to think about. I would also wonder in a young person if there was a history of marijuana use. But ultimately, I think it's important not to have a reflex of turning down a donor like this with this kind of positive culture result. It's certainly important and concerning, and it's going to impact your post-transplant prophylaxis. But I think you're probably still comfortable going forward, especially for a heart liver at this point.
Yeah, great. Certainly lots to think of in this case. Okay, so continuing in our case, yes, so we changed tact and our patient is started on oral posaconazole on post-transplant day 7 with a planned duration of approximately 1 month of treatment. The following day, on post-transplant day 8, our patient has their first routine endomyocardial biopsy, which shows one non-necrotizing granuloma. On this biopsy, the GMS stain for any causative organisms is negative, and there's no significant acute cellular or antibody-mediated rejection. Unfortunately, all the tissue was collected, fixed in formalin, and we didn't have any fresh samples to send to our microlab. But what we were able to do is able to send off the fixed tissue to the University of Washington for some broad-range PCR testing. And we get the following results: Mycobacterium tuberculosis complex DNA not detected, non-tuberculous mycobacteria DNA indeterminate, fungal DNA not detected, and bacterial DNA detected Cutibacterium acnes. So my next question to our panel is, our patient's doing clinically well. Is there any additional workup or treatment that you'd like to do at this point in time?
So at this point, I'm a little bit concerned about the non-necrotizing granuloma. I do, appreciate that the GMS stain was negative, and there didn't appear to be any other concerning pathology. I think as we all appreciate the challenges of having tissue fixed in formalin and not available to culture always make things more complicated. Knowing the donor's history and potential exposures, I do worry about what this granuloma may represent, whether it could potentially be reflective of a mycobacterial process, fungal process, although again, noting the GMS stains negative. The broad range PCR results are interesting. We see that the MTB complex DNA was not detected. Neither was fungal DNA. The identification of Cutibacterium acnes on bacterial evaluation, I don't know that I'd put much stock into that. I wonder whether that may be contaminant. And it's hard to know what to do with the non-tuberculous mycobacterial DNA being indeterminate. I don't know whether this is just sort of whether this reflects in this case something that's really true and ongoing, whether this could be potentially a sort of falsely indeterminate result. But I do always worry about kind of certainly the ability to send off broad range PCRs on the fixed tissue is always helpful. But I always, in the back of my mind, really do worry about the validity of some of the test results, particularly when tissue's been placed in formalin. So I'm still a little bit worried about this, but at this point, patient's doing well. I suppose, potentially other evaluations for, mycobacterial disease could be undertaken, but again, feeling well. And I don't know whether others have thoughts on what their next steps might be.
No, I definitely agree. And you highlighted before, Dr. Pouch, some of the TB risk factors in this donor, which is very important. I wanted to comment on something you didn't say, which I agree with, is that asking the OPO to run a quantiferon gold or other IGRA test is not going to help you, and they probably don't have the serum at this point in time anyway. Those IGRA tests are not they're not designed for brain dead donors, and they often have indeterminate results. So it's really not going to help you get out of this pickle. You're going to have to solve what the next step is clinically, as mentioned, not through serology testing on the donor at this point.
Great, thank you to our panel. We'll keep going on with our case. So yes, we don't change tack with these results either, but we were thinking of these other processes. So now let's fast forward to 7 weeks post-transplant. Our patient completed their 4 weeks of posaconazole a few weeks ago, but they now present with fever, back, and hip pain. Initial workup shows a pretty normal CBC with a normal renal and hepatic panel. Blood cultures are negative, a chest X-ray is clear, and a transthoracic echocardiogram is unremarkable. An MRI of the hip shows numerous small enhancing lesions throughout the left proximal femur, and the MRI spine shows multifocal enhancing bone lesions throughout the vertebral bodies, particularly involving the posterior elements and sparing the discs. Patient gets some more diagnostic workup. So with this, we have an EBV PCR in whole blood that's detected below the lower limit of quantification. We've got some fungal markers that are sent off. So we've got negative beta-D glucan, a negative serum galactomannan, and a negative serum cryptococcal antigen. Coccidioides serology is negative. A urine histoplasma and blastomyces antigen is negative. And because of a non-diagnostic initial workup, our patient proceeds to get a CT-guided biopsy of the L3 vertebral body lesion. And unfortunately, again, all of the tissue was placed in formalin and none was sent to our microlab for culture. But what we get is a pretty normal histopathology result. So we can have normal bone, no signs of infection, no acute osteomyelitis, no granulomas, and additional stains for acid-fast, fungal, and bacterial organisms are all negative. So, throwing back to our panel, what processes currently are highest on your differential with these test results, and what are your next steps in evaluation?
So the plot certainly is thickening. So now there's, apparent bony involvement. Whether it's the same process or not, I think is still a question. I think looking at the results that have come back so far, we see that there's a detectable EBV viral load done on a whole blood, less than 568 IUs per ml. In my mind, I'm not thinking that this is, probably related to what the acute issue is, and is more likely, based on what I have in front of me right now, if anything, probably some degree of reactivation in the setting of whatever other acute illness is going on. Although certainly, and I believe the donor or the serostatus was EBV positive, as I recall. So seems less likely to be a PTLD picture. So far, the non-invasive fungal testing is negative. And as we see here, we have other serologies and antigen testing that's negative, which makes me feel a little bit, more inclined to think that this is likely not a fungal process, although more information I think is still needed. And again, we're faced with the issue of not having tissue available for culture. And based on the results that I'm seeing here, I do wonder whether there could be, is the biopsy really normal in that area that looked so abnormal on imaging? Could there be sampling error or other things going on? So, at this point, knowing the donor history, kind of going back to what we know of exposures and the like, I still have to admit I am a little bit worried about I'm still worried about mycobacterial infection, including TB. I think right now, next steps in evaluation are challenging. It sounds like there I don't know, I'm assuming may not be anything else that's, easily accessible in terms of biopsy. But in these situations, I generally have not historically sent cell-free DNA, but I think that might be something to consider in this case as well, knowing that something is going on in this recipient of a donor with certain risk factors for TB and other infections, and we still have yet to find an answer. And I'll say I worry about tests that do rely on immune response. I think Joanna had put this in the test, or excuse me, in the chat as well. So yeah.
Great, thank you. Yes, so we did really want to get some fresh samples for culture. So we did proceed to go with a repeat CT guided biopsy, and we did go ahead with a plasma microbial cell-free DNA test just because we thought it'd be quite a while until we get that repeat biopsy. And that result came back with a positive result for Mycobacterium tuberculosis. We then look through our recipients' pre-transplant testing, and we note that their quantiferon gold was negative. And in addition, they didn't have any sort of clinical or epidemiological risk factors for TB acquisition before or after transplant. So this case was reported as a potential donor-derived infection and reported to our public health department. And on return of the plasma cell-free DNA test result, we start our patient on upfront TB therapy with rifabutin, isoniazid, pyrazinamide, and ethambutol, and manage some drug-drug interactions as well. We get the repeat bone biopsy 2 weeks later, and that is smear positive and culture positive for Mycobacterium tuberculosis. We also send off some urine mycobacterial cultures, which flag positive for Mycobacterium tuberculosis at the 5-week mark. And we sent off some mycobacterial blood cultures, which were negative out to 6 weeks. And with this result and concern for tuberculosis, our donor mycobacterial BAR cultures were sent, and they were negative out to 6 weeks. As you can see, our susceptibility in the bottom right-hand corner is fully drug susceptible TB. So when we get this result back at around the 2-month mark, we stop their pyrazinamide and ethambutol and continue on 12 months of rifabutin and isoniazid for disseminated TB in an immunocompromised patient. Bonus question for the panel, though, is suppose that you're caring for a kidney transplant recipient and you're notified that a heart liver recipient of the same donor has been diagnosed with TB in the early post-transplant period. Your kidney recipient is clinically doing well and has good graft function. How would you manage this patient? What diagnostics, if any, would you send? And would you offer this patient empirical TB therapy? And if so, would it be active or latent TB therapy?
All right, this is a fantastic question. I'll just say, the kind of conclusion of the case was fantastic, knowing that the case was reported for biovigilance purposes, but also I want to underscore the critical importance of all of the communication that ensues when these events happen. And in this case, also inclusion of public health officials. And oftentimes, when we have donor-derived TB transmissions, a lot of times they're multi-state and multi-agency collaborations that are required to ensure that all recipients are appropriately managed, contact tracing occurs, et cetera. So that communication is really critical, which gets to this question that now comes up, wherein we're asked, what would we do if we had the mate kidney recipient? And so I think, the first comment that initially comes to mind is that oftentimes when we hear that a mate recipient is ill, we frequently get very little information. It may just be, recipient has TB in this case with very little additional information. So what I would always do in these cases is, one, go back and review in full detail the donor chart, including imaging, testing, exposures, et cetera, to really understand how I need to be thinking about risk stratification for disease transmission in my recipient. So knowing this donor history already, I have a heightened concern that this could be a donor disease transmission from the shared donor. But I think the other piece relating to communication is, whenever possible, it's fantastic to be able to get in touch with the center who has the other recipient or recipients who may be implicated in this case, in order to get a little bit more information about what may be transpiring in that recipient or what their thought processes are. But knowing what I know of this case and presuming I had all that information in front of me, even though my kidney recipient might be doing well and has excellent graft function, I'd be very concerned in this particular case. Certainly diagnostics would be something to consider pursuing, whether it be, in this case, I don't know, urine AFB cultures. But I think particularly when I'm envisioning, donor-derived TB, particularly in a non-lung recipient, oftentimes these patients present with disseminated disease. So limiting my evaluation to pulmonary evaluation or what have you may be limited. So really taking a thorough evaluation clinically of that patient to kind of figure out what my next steps might be. But in this particular case, given the concern that there very well may be a disease transmission, and I'll also say that ultimately, and this will be kind of down the road information that might come back, knowing the genotype results might be helpful in determining disease transmission. But nonetheless, in this case, I actually might be compelled to actually start treatment for active TB in my recipient pending additional information. Challenge with that is always the drug interactions, as you had highlighted on the previous slide.
Great. Thank you, Dr. Pouch. Any differing opinions from the rest of our panel? Or
Yeah, this is tough. You're asking about the kidney. Certainly, if I had taken the lung from this donor, I would start for drug therapy because we know the risk is so much harder. For the kidney, I love that suggestion of sending an AFB urine culture and looking closely at the donor imaging studies. I might be satisfied with just latent TB treatment for the kidney if I could convince myself that probably the burden of transmission maybe came with the liver in this heart liver case. But probably starting active TB therapy and then backing down is probably a better answer than mine. But you might have to convince the nephrologist, though, like you mentioned about the drug-drug interaction. But the point is, you're certainly not going to ignore it.
yeah, definitely. Great. Okay. Well, I just wanted to end this case just on a very brief summary of donor-derived tuberculosis and particularly the donor evaluation. We have talked about this already, so I just wanted to highlight that there are limitations at sort of every step of the process of going through TB evaluation, particularly in deceased donors. So it's not always possible to definitively rule out TB in every case. As we've said before, this happens at the donor risk factor screening process and also in all the tests that we rely on for active TB evaluation and latent TB evaluation. When we look at the epidemiology of donor-derived TB, we can see that it's relatively rare, occurring in less than 5% of all TB cases in solid organ transplant recipients. And what's rather unique about it is that it does present early after transplant, with a median of 2 months after transplant, whereas all other non-donor-derived TB cases occur much later, normally after a year after transplant. And it does seem to present slightly differently in different in different transplant recipients. So lung transplant recipients more commonly present with pulmonary TB, and non-lung transplant recipients more commonly present with disseminated or extrapulmonary TB. We also see high proportions of allograft involvement, as we saw in our case with the endomyocardial biopsy result. And because this diagnosis is often delayed in recognition and starting treatment, outcomes can be poor with a mortality estimate of around 24% and graft loss of around 19%. So the clinical takeaway from this is that we should suspect donor-derived TB in any solid organ transplant recipient who has unresponsive fever in the immediate to early post-transplant period. And that's particularly the case when donor TB risk factor assessment is incomplete. And early recognition and notification are critical in order to improve outcomes in other recipients. So I'll pause there and hand over to our next case.
Thanks, Dr. Collis. So I'll talk about case 2, a tale from Texas. So the setting is summertime in Texas, and our potential donor is a 48-year-old male brought in by EMS from work at an oil rig with uncontrollable seizures and suspected heat stroke. At this time, he has very high liver enzymes and CK. He was acting normal the morning of presentation and then abruptly started not acting right prior to his seizures, reported feeling unwell 3 days prior. His temperature was 41.6 degrees Celsius on arrival to the ED. He had a cardiac arrest in the emergency room and ultimately was declared brain dead. There were no known risk factors for bloodborne pathogens. His blood cultures at presentation were positive for MSSA in 2 out of 2 sets, and he received antibiotics with blood cultures becoming negative prior to procurement. His TTE was done and unremarkable. So question for the panel is, does this donor warrant further investigation for infectious causes of his hypothermia and seizures?
So this seems like a leading question, Dr. Nelson. I would say the answer is definitely yes. I think one of the most important take-homes for thinking about donor-derived infection is to think about viral encephalitis. And this would be a classic situation where you could have some mosquito exposure. Maybe there's some other animal exposure out there on the rig. And we know that these viral encephalitis cases are often fatal in recipients. And we usually don't have therapies that we can give to prevent transmission or to ameliorate donor-derived infection. So my first thought on hearing this case would be to think about a viral cause, such as West Nile virus, rabies, LCMV, or one of the equine encephalitis viruses, and make sure that there had been lumbar puncture performed in this donor if possible. In terms of the blood cultures, that would be another possible cause of this presentation. So you have a TTE that's unremarkable, but you might want to talk to your cardiologist to actually review the images, make sure that they're happy with the windows and the visualization. A TEE might be recommended. And then you're going to want repeat blood cultures, and hopefully those cultures being negative so far if you're even contemplating using organs from this donor.
Great points. Dr. Pouch, did you have anything else to add?
I agree with everything that Dr. Schaenman had said. I think the other thing that stands out to me is that, the initial presentation may have been compatible with heat stroke and certainly could have been a contributing factor. But the fact that there's some, or at least report that he had been feeling unwell for several days or for a couple days prior to presentation also raises a bit of a red flag.
Yeah, great point. Okay, so the donor CT chest report reads with some abnormalities. So there was narrowing of the bronchus intermedius with airspace opacification of the right middle lobe, consistent with a consolidation. There was some obliteration of the right lower lobe bronchus with some post-obstructive atelectasis or consolidation, with some mediastinal shifting, consistent with possibility of an underlying mass lesion, couldn't be ruled out completely. And then the right upper lobe showed some confluent airspace opacities with interstitial thickening in keeping with pneumonitis. The donor did have a bronchoscopy which showed copious thick brown secretions bilaterally, and the BA cultures were negative. So our potential recipient was a 65-year-old man with rapidly progressive ILD who is listed for bilateral lung transplant. He currently was on 25 liters of O2 as an outpatient. He was blood type O positive. He did not have any prior sensitization. His cath was within normal limits except for a high PA pressures. His height was 72 inches and weight 94.3 kilograms. And you can see his chest dimensions listed here. So I wanted to pause for a minute to talk about some surgical considerations for the donor with a lung mass and the potential recipient. I'm wondering, Dr. Haney, if you can comment on how you assess lungs for transplant suitability.
Sure. Thank you very much for having me. I always enjoy listening to people who are way smarter than me. So, I mean, obviously, we have a limited amount of information about these lungs, right? We see them; they don't look particularly anthracotic. They actually look quite good. But probably the one of the biggest keys here that we've learned over the last few years is that really it's not about oxygenation, it's not about appearance, it's not about bronchoscopy, it's about dynamic compliance. That is the single most predictive metric to measure lung suitability for transplants, dynamic compliance. Remember, 90% of patients have some bacteria on their BAL. These are people who are intubated, they're dead, bad stuff happens, right? So they're all going to have some degree of culture. And there's certainly cultures that you'd expect, and there's cultures you wouldn't. But they're going to have some degree of crud in their airway. There's a big difference, and it's very hard to tell from preoperative imaging whether they have atelectasis versus consolidation. And that's where dynamic compliance comes in. A really consolidated infected lung has poor compliance. One that's atelectatic usually does not. And so that's sort of the preoperative imaging. Basically, I wouldn't discount an organ based on the report of the bronchoscopy and the preoperative imaging, essentially. So when you were to go and look at these organs for transplant, and obviously we can see they've already been recovered, they look good, we'd basically find out some more information about them. We'd find out how their compliance was. We'd find out how the bronchoscopy cleared. There's a big difference between sucking out a bunch of mucus and stuff that's obstructive, but then doesn't reaccumulate versus one that continues to reaccumulate from the lower lobe, right? So you get a lot of information from sort of the real-time bronchoscopy. My guess looking at that lung is that it did not feel consolidated, that they sucked out the airways, that they didn't reaccumulate, and that the lung, felt relatively compliant on palpation and upon testing it and ventilating it. And so I think a lot of it, and we don't see the lower lobe here, a lot of it has to do with sort of the dynamic assessment of the organ, in the field, and that's actually one of the reasons for sending organs for EVLP when you don't have the same ability to measure it in like a DCD donor. But so in this case, I think we have a little bit of imperfect information. I'm going to assume those lungs look reasonably good, and that if they were going to be good, it's because their dynamic airway compliance was good, their bronchoscopy cleared, you sucked all that stuff out, and then the lungs and the lobes felt reasonably compliant when you ventilated them. The other thing I'll say about that recipient is, here we have a gentleman who's on 25 liters of oxygen. He's got moderate pH, mean PA pressure of 30, and we'll get into sort of what was done. But essentially, that's a guy, remember, we're in the era of CAS, so you can't tell him exactly what his score is. It depends on the location of the organ, but that's going to generate a pretty high score. He's on a lot of oxygen. He's an O, so he's going to wait a little bit longer, but he's on a good bit of oxygen with pH. His wait time is not going to be dramatic. He's not, he's tall, he's like 6 feet tall, and he's not sensitized. So I would put him in a category of a patient who does not have dramatic barriers to transplant. And I say that because one of the things that's become, I think, more and more apparent is it's not just about what lung is suitable, it's about what lung is suitable for the appropriate recipient, right? And this is something we've learned, whether it's liver transplant, they probably showed it the first, but heart transplant, lung transplant, right? It's not necessarily about just taking any lung, it's about matching it for, is this the right lung for this person? And so I would say he's someone who I'm interested in transplanting. I think is certainly getting sick. He's already got some pH. He's on 25 liters of oxygen, but he's not on ECMO. He doesn't have any obvious overt barriers. So I'm going to be in him probably a little bit thoughtful about the organ because I also think he's going to have a CAS score that's probably, 37, 38. He's going to get transplanted within a couple weeks.
Okay, great. Thank you for your insight. That's all really helpful to hear. Okay, so back to our potential donor, a little bit more about his history. So he works at an oil rig, as I mentioned before. He was born in northern Texas. He did have a history of coccidioidomycosis about 11 years prior. This was diagnosed by a lymph node biopsy. We're not clear from where this was. It was treated, but he wasn't on an antifungal therapy at the time of his death. He also has a history of shingles of the left eye 11 years prior with corneal damage from this. He did have a lymph node biopsy during the donor evaluation, which showed prominent hyaline fibrosis, suggest clinical correlation. So, question for the panel, does this donor's infection history impact your decision to accept lungs from the donor?
So yes, the plot thickens, and I was just thinking that working up these donors is always so challenging. It's like a medical mystery where you're not sure like what's a red herring versus what really connects. Is this someone who has an infection syndrome that's affecting the CNS, leading to the altered mental status and the lung, or are these two true and unrelated syndromes? So still a lot of questions here. Maybe I'll just assume for the sake of argument that we do have a lumbar puncture and we've reassured ourselves that the altered mental status was related to heat stroke and the bacteremia it has resolved in follow-up cultures. We still have someone who's got a lung mass that's causing bronchial stenosis. So we're going to reach out to our procuring surgeons and ask them to take a look at that if we go forward, thinking about malignancy, which we really don't want to transmit, as well as infections that can cause a mass. And so that would include tuberculosis and also so-called endemic fungi. Now, we know in medicine that history often repeats itself. So, this combination of Texas, which is in the Southwest, an endemic area for coccidioidomycosis, plus a history of cocci, and now a positive biopsy showing hyaline fibrosis. This is all kind of pointing towards maybe this donor does have cocci. I think unclear at this point in time whether it's a chronic cocci, like a latent TB situation, or whether the cocci is for some reason reactivating, leading to meningitis due to this fungal infection. So this is definitely going to cause pause. I think, as Dr. Haney mentioned, the lungs are already out, so maybe you're getting this information late. But I like that point about matching the donor and recipient. So if you're hearing about this early, this is a time where maybe I would reach out to my pulmonology team, the surgeon and medical experts, and say, is there someone on ECMO who's hard to match, who's sensitized, or is this someone, as mentioned, who's got a high CAS score? Maybe this is a risky donor and we could say no, wait for the next offer. But if we're at the point where we've already gone forward and these lungs are already in our patient, now we need to think in a strategic way about what we can do as ID consultants to decrease risk of donor-derived infection. So I think tuberculosis is still on the table here, as well as coccidioidomycosis. So I would make sure that this lung transplant recipient is on an effective anti-mold prophylaxis regimen that would also provide coverage for cocci at this point in time.
Let me make one comment about that timing issue. And yeah, listen, surgeons love to put ID physicians in bad situations, right? We make decisions that are put you behind the eight ball to start. But lots has changed in lung transplant, right? So we no longer have, we often will get this information beforehand, right? We have a window of 24 hours potentially with good lungs in just cold static storage with a good temperature control to do the implant. So we are frequently now slow playing lung transplant in a way that we aren't yet really for heart transplant, and it allows us to get some of this data, right? Things like your lymph node biopsy, and we will often wait. Obviously we're doing less transplants in the middle of the night. So there is a chance that we get this data back beforehand. I would not take this donor. I think if truly if there is a question of a mass lesion, right? Like I'm assuming when we talked about it, we did the bronch, we sucked everything out, and it's not stenotic. But if there's question of like some sort of mass lesion in the parenchyma with that history of fever, with this lymph node biopsy, like I'm probably turning it down. And I'm probably turning it down because, like we said, this isn't this patient's one shot, right? This isn't a PRA of, you're gonna take risk. There's no question. And one of the things that we always talk to patients about is this is about relative risk, right? We all worry about, the transmission of like hepatitis X that no one's ever heard of before, right? But the entire transplant process is so incredibly risky. It's a matter of where you put your risk. So if it's the patient's one shot, if it's a pristine lung, young person, no smoking, looks great, sure, I'm going to probably take more infectious risk potentially. In this case, I agree. This history and these findings then would make me nervous if that's in fact what we found.
Great discussion. Thank you. Okay, so ultimately the lungs were accepted for bilateral lung transplant. The donor had a right lower lobe lobectomy performed prior to implant due to the small chest size and grossly infected appearance. A 2.2 centimeter cavity was noted. Our recipient was started on fluconazole post-op day 1, which is the institutional protocol for Candida prophylaxis. The recipient was also treated for over 14 days for the donor MSSA bacteremia. The pre-procurement donor BAL cultures that were done were negative, but our post-procurement donor BAL cultures, so those that were done at the time of OR implantation, were positive for coccidioides posidasii. And you can see on the right the donor histopathology. So the upper picture is the GMS stain from the lymph node biopsy, which shows these classic thick-walled spherules consistent with yeast forms of coccidioides. And then the bottom is from the lung biopsy, which showed septate hyphae, which is the arthroconidial form of cocci, which is fairly atypical to see actually in tissue biopsies. And for that reason, the sample was sent for PCR, which did also identify coccidioides DNA. So the recipient was maintained on fluconazole and is doing well 9 months post-transplant with a plan for lifelong therapy. So just wanted to pause and talk briefly about donor-derived coccidioides. This is from a recently published report also from the DTAC looking at 10 years of data in the US, looking at potential cocci donor-derived transmissible events. So ultimately, they found 7 cocci-positive donors, which transmitted organs to 20 recipients. So importantly, these 7 donors all were living in or had previously lived in endemic areas for cocci. They were microdata was kind of across the board, with one having a positive BAL prior, which resulted post-transplant, one with positive serologies pre-procurement, and 3 who had serologies later retrospectively, which turned out to be positive. 8 recipients, so 40%, developed proven or probable cocci, 5 liver and 3 lung. In these recipients, the time to diagnosis was relatively early post-transplant, 39 days post-transplant. Many were diagnosed with positive respiratory cultures, and importantly, 6 developed disseminated disease, with also 6 dying related to their cocci infection. 11 recipients had intervention where they were started on prophylaxis and did not go on to have evidence of disease with cocci, and these included 2 hearts, 7 kidneys, 1 kidney, pancreas, and 1 liver. Can go on to the next slide. So one point I wanted to make about cocci is just the evolving landscape here. So reports in the literature show seropositivity of transplant, pre-transplant candidates of 1.4 to 5.6% in endemic areas. And you can see in the maps on the right, this cocci is generally found in kind of dry, arid climates of the Southwest US, as well as globally in North America, Central America, and pockets of South America. But really importantly, the overall incidence in these endemic areas is increasing, and geographic distribution is also expanding and expected to expand even further. So this might be an issue that becomes a lot more relevant to more of us across the globe. At the bottom here, I have a schematic from this recent OPTN manuscript, kind of suggesting what we should do for donor evaluation and recipient management. So definitely if the donor has any history of cocci infection, considering starting the recipient on antifungal therapy. Important things to recognize: if the donor is from an endemic area and or has abnormal chest imaging, to consider doing some additional workup. Definitely, if that workup is positive, to start your recipient on antifungal therapy post-op. It's debatable whether, if this workup is negative, to just go ahead and start recipient on antifungal therapy prophylactically, especially probably in the setting of abnormal chest imaging. And then lastly, if other recipients from the same donor develop coccidioidomycosis, then to think about it in your recipient and start that person on antifungal therapy. So this is really an area of ongoing discussion. How is absolutely the right way to manage recipients, whether we should do universal screening, whether anybody, how we should deal with recipients from donors from endemic areas, but really just want to highlight that it's something we should think about in donors coming from endemic areas.
Okay, thank you, Dr. Nelson. We did have a third case planned, but unfortunately we're running out of time and won't be able to cover it. So just with the last few minutes of our webinar, I just wanted to throw it back to our expert panel if they have any final comments on difficult donor dilemmas or donor-derived infections from any of the content that we've covered.
I was just going to make a comment about case 2. And thinking through this, the other question that came to mind, knowing that the donor had, I guess, zoster, 10 years ago, and they were relatively young. The other question that comes to mind is whether there was any other underlying immunocompromise, which I just bring up because our donors in general are becoming more medically complex, and we're starting to see an increasing number of donors that may have underlying immunocompromising conditions. So just something I'm always thinking about when I'm evaluating a donor in terms of risk. While I'm either evaluating the donor, wearing my kind of OPO hat, or when I'm thinking about how best to potentially mitigate disease transmission in a recipient. And to get to the point of, wanting to make sure that we have the right organ going to the right person at the right time, if this was, I think, if there are questions about, something might not be right with this donor, but it's not a hard stop. And, you may have someone who's waiting, who this might be their one chance at getting an organ. From a donor evaluation perspective, again, kind of wearing more of my OPO hat, I always try to collect as much information as I possibly can to be of help to the transplant centers, knowing that a lot of that information is not going to come back until after a transplant. So when there are, when there's lymphadenopathy, for example, in the context of whatever might be going on, if it makes sense, I like to biopsy, send cultures and path, not only frozen path, but also fixed formal or fixed permanent after the fact. Again, knowing that these results will come back later, but at least it's something that will be available to centers. Certainly, taking into consideration the individual case at hand.
Let me say from a surgical standpoint, and every program has different workflows, right? So as Transplant ID, you may or may not see donor data. You may not have an opportunity to review donor data before an organ is accepted. But if you do, never overestimate the intelligence or thoughtfulness of a surgeon. Okay, like we sew things in a circle for a living, and I have never. I don't know a surgeon who would ever be disappointed in an infectious disease expert raising a question prior to implanting an organ. And I would encourage you to not be afraid to raise an issue. As I said, with lungs, we often have longer periods of time than we used to. And frequently there may be very good reasons that have been well thought out beforehand. But as I said before, surgeons are frequently putting infectious disease doctors, in harm's way, sometimes unintentionally. And even if it's just going through the medical providers as well, I would always encourage someone who spends the time to look at a donor and say, it's kind of funny. This guy had a febrile illness to 41 and seizures. I'm not sure we've really ruled out West Nile virus appropriately. I think that's the kind of thing that most of us as transplant surgeons would appreciate. So I would just put in a plug for don't be afraid to raise your hand and don't assume the surgeon has already been as thoughtful as you might think about the infectious implications.
I appreciate those comments. I think in the spirit of ISHLT, I think emphasizing the importance of interdisciplinary communication is so important. As you pointed out, Dr. Haney, this is a recipient who maybe could have waited for another offer. But I sometimes hear about my colleagues turning down organs that do have risk, like, for instance, a donor with a history of staph bacteremia but on appropriate treatment for a non-heart recipient. And they're saying no, and maybe not taking the time to reach out to the pulmonologists or surgeons who will say, this person has waited, they have lung dimensions that are very hard to match. And I think sometimes when ID says no, the team hears that as it's an absolute no, when really what we need to be maybe communicating is this is a donor that has some risks. And we need to really be specific as ID physicians. Is this a risk that cannot be mitigated, like a concern for rabies or West Nile? Or is this a risk that can be mitigated with prophylaxis, such as continuing Staph aureus therapy or targeted antifungal therapy that would allow us to decrease risk if it's a recipient who's really limited in their donor options? So I really feel like that two-way street is so important between ID and the transplant team, and often we're being paged in the middle of the night by coordinators who may not have the full picture in terms of the recipient. And in the spirit of communication, I wanted to also emphasize something Dr. Pouch said about communication with public health and also the OPO. And I think often on the transplant center side, we're very dependent on the donor summary. And there's often a lot of information in DonorNet, including the social history and including the imaging studies and studies such as a lumbar puncture that may not make it to that summary. So it's so important when you have concerns to go back to the primary source and review information like donor birthplace, donor geographic exposures, and chest imaging, even for a non-lung recipient. And then when you get a confusing result, such as this, I think it was the hyaline fibrosis, it's not a phrase that trips off my tongue, that you're reaching out to the OPO to get clarity, exactly what was seen, can we get more information? You may not be able to get additional procedures performed. For instance, the OPO may be reluctant to perform an LP, but you may be able to get more information and wring out every last piece of data that you're going to need to make an informed decision from the procedures and from the test results that have been performed. So just very important to take that extra step, again, as Dr. Pouch suggested, and reach out to the OPO, and then they can potentially reach out to the donor hospital to get you that information you might need.
Great. Thank you to our expert panel for their final comments. We've just got 1 minute left in the meeting, so I just want to say thank you to our co-moderator, Dr. Joanna Nelson, and a big thank you to our expert panel, Dr. Jack Haney, Dr. Stephanie Pouch, and Dr. Joanna Schaenman for their expert opinion and excellent discussion on some complex donor-derived infection discussions. So with that, I'll draw the meeting to a close, and thank you everyone for your attention.